You're trying to conceive and still not getting pregnant. Your IVF is continuously failing in spite of embryos are normal, endometrium is normal, and uterus is normal. There might be a silent condition called as hydrosalpinx. The shocking truth is that hydrosalpinx, if it is present, it leads to about 50% cases of IVF failure. And most awe-inspiring fact is that most of the hydrosalpinx do not have any symptoms. Hello, I am Dr. Rajat, I am an infertility specialist, and today in this video I will tell you everything about hydrosalpinx, what hydrosalpinx is, how it affects pregnancy, and by the end of this video you will definitely know whether this hydrosalpinx can be treated by medicines. Does hydrosalpinx need to be removed? What are the surgeries we do for hydrosalpinx, and what does hydrosalpinx removal do to your IVF? Good morning, good afternoon, good night, wherever you are. I am your host and your host, Dr. Rajat. I am a gynecologist and you have started watching our YouTube channel, The Fertility Gynecologist. In previous two videos, I have discussed about HYDROSALPINGECTOMY. I have discussed about what to do when there is a blocked fallopian tube. In this video, we will discuss what is hydrosalpinx. Hydro means water, salpinx means fallopian tube. So, whenever the fallopian tube is filled with water, it is called as a hydrosalpinx. This is a diagnosis which is a hysterosalpingography diagnosis. Many of my colleagues, many of other routine gynecologists, they do a procedure called as sonosalpingography. While sonosalpingography may tell us about the patency of fallopian tube, but I am a conventional old world guy who still believes that a hysterosalpingography is the first and the best possible modality to diagnose the patency of fallopian tube. I always mention two words. Fallopian tube patency is different from fallopian tube potency. Fallopian tubes are not simply open pipes in which you can just put the dye and show whether the dye is coming out, whether the fallopian tube is patent or not. Anatomical patency is different from a functional potency. I mentioned in my previous videos that fallopian tubes have got cilia, and those cilia, they basically are hair-like structures which function to transport the ovum from the fimbria to the middle part, and from once the embryo is formed, the embryo is transferred to the uterus. What happens is, in blocked fallopian tubes or in hydrosalpinx, these cilia are damaged, and the moment these cilia are damaged, that is why there is a difficulty in conception or the chances of ectopic pregnancy increases. So in a simple language, hydrosalpinx is a fluid-filled fallopian tube. Hydrosalpinx can be patent or it can be blocked. When there is a collection of fluid in the fallopian tube, initially the fallopian tube is patent, and the longer the collection goes, the longer the damage occurs in the fallopian tube, there might be a blockage at the femoral end of the fallopian tube. So in this video, I would like to tell you, what if your doctor has told you on an HSG that you have a hydrosalpinx. Now let us come, whether you can conceive. The most important question in your mind is whether you can conceive normally or not. Do you require IUI or do you require IVF, or whether you can do IVF with your fallopian tubes which are suggestive of hydrosalpinx, whether unilateral hydrosalpinx is there or a bilateral hydrosalpinx there. We'll cover each and everything. Now if your HSG says that there is a hydrosalpinx on one side but the fallopian tubes are patent, what would you do? In my experience, if the fallopian tubes are patent and it suggests mild or moderate hydrosalpinx, yes, there is an infective damage to the fallopian tubes, and usually if there is a single side hydrosalpinx, that doesn't mean that the damage would be only in that side fallopian tube. It suggests that the damage might be particularly more in that side of fallopian tube, while damage might be in both the fallopian tubes. In any kind of an infective damage, femoral tube block or a fallopian tube which is suggestive of hydrosalpinx, I normally give a good long course of antibiotic for about 3 to 4 weeks. Doxycycline is our most favored antibiotic as far as gynecologists are concerned. We give it for 3 to 4 weeks. So if a hysterosalpingography report is suggestive of fallopian tube which has hydrosalpinx but it is patent, I'll give hydrosalpinx and will try for at least 3 to 4 cycles post hysterosalpingography with ovulation stimulation and follicular monitoring. And there are 20 to 40% cases who may conceive after doing HSgraphy with doxycycline. Suppose the patient still doesn't conceive, then there is a chance that this may be considered as an unexplained infertility, and we may go for control over hyperstimulation with intrauterine insemination. Why hydrosalpinx affects pregnancy as such? Because I mentioned hydrosalpinx means there is a collection of fluid inside the fallopian tubes. This fluid, even if it is patent, this fluid constantly drips from the cornu inside the uterine cavity. And the function of fallopian tubes is just the site of fertilization of sperm and the ova. Once the ova is fertilized and it becomes embryo, that embryo is transferred to this. Now just imagine if the fluid is constantly dripping inside the endometrial cavity. Would embryo stick when there is a fluid? Just simple thing is, imagine this is a piece of paper and I want to stick another piece of paper over it. I'll apply glue and then I'll try and stick it. But if this paper is wet and I apply glue or some kind of fabric, would this stick? The wetness of this tissue would prevent this paper to stick to this thing. The same logic applies in the uterus, and that is why the hydrosalpinx patients find it difficult to conceive. But the advantage with patent fallopian tubes and hydrosalpinx is that fluid is constantly dripping from the femoral end also and constantly dripping from this side also, and with mild to moderate antibiotic cover, most of the infection can be taken off. As long as fallopian tubes are patent, we do not do any surgical intervention as far as the hydrosalpinx is concerned, whether it is a unilateral hydrosalpinx or bilateral hydrosalpinx. If fallopian tubes are open, we give a good 3 to 4 weeks of antibiotics, either single antibiotic or one antibiotic followed by other antibiotic. In our gynec, doxycycline, ciprofloxacin and azithromycin are the best antibiotics which we normally give, and we ask the patient to try for 3 to 4 cycles. Suppose there is a hydrosalpinx and it says there is a one fallopian tube is blocked but other fallopian tube is normal. What to do in that case? In that case also the treatment line would be, modality would be same. We would again give a good course of antibiotic, and for next cycle we'll start controlled ovarian hyperstimulation depending upon the other factors, whether there is a male factor, whether the semen counts are normal or low, or there is a female factor, whether there is an adenomyosis or fibroid or decrease of ovarian reserve, or patient's age is more, female age is more, one tube is blocked, then we may plan for intrauterine insemination from the next cycle. If suppose right side fallopian tube hydrosalpinx is there and on the left side there are good follicles, number 1 or 2 are formed, then we may plan for IUI for 3 to 4 cycles. And if the patient does not conceive in those 3 to 4 cycles, then we may refer the patient for an IVF. Now comes the role of surgery in a hydrosalpinx. First of all, if hydrosalpinx with both the fallopian tubes are patent, I personally do not think if the patient is wanting to try for a normal pregnancy or an IUI, there is no role of any surgery. But if there is a fallopian tube block, there is a balloon pouching and the dye does not come out through the femoral end, either one side or both the sides, and we have tried enough, whether there is a unilateral fallopian tube block, we have tried enough, or if there is a bilateral hydrosalpinx with bilateral femoral block, then in that case there is no chance that a normal pregnancy can occur. We will have to definitely go for a laparoscopy. Now what do we do in a laparoscopy? If only finding is hydrosalpinx, patient's AMH is normal, patient's age is normal, patient's husband semen count is normal, then we have an option of doing something called as an femorioplasty. We may create a new opening. This femoria is blocked. What do? Is we try and open this femoria and do something called as a femorioplasty, and we try and open the fallopian tube from both the sides, and we check by a laparoscopic chromograph cultivation the fallopian tubes are normal, and post laparoscopy we can go for a again controlled ovarian hyperstimulation with or without IUI depending upon the patient's other high risk factors. We may try for 6 to 8 months, still patient does not conceive, then we may go for IVF. Now, do all the hydrosalpinx patients need IVF? Answer is no. Again, like I said, a single factor cannot decide the treatment modality, whether the patient should try for a natural cycle or IUI or IVF. It is a combination of various factors. What is the patient age? What is the patient's AMH? What is the husband's semen count? How long have patients been trying? What is the patient's previous obstetric history? How many children are there? Everything decides what modality, how long they should try, whether they should go for IUI or whether they should go for IVF. Suppose patients have been previously diagnosed hydrosalpinx, they have tried enough after hydrosalpinx, they have undergone laparoscopy, that fallopian tubes have been opened, still they have tried enough, they have tried couple of cycles of IUI or multiple cycles of IUI, still they do not conceive and they want to go for IVF. Now the question is, do you need to remove hydrosalpinx before going for IVF? In an ideal world, if patient cost is not a concern, yes, I would like to remove the damaged fallopian tubes by doing a laparoscopy before IVF. Removing the damaged fallopian tubes, what it would do is, first of all, like I mentioned, you have to understand that the hydrosalpinx fluid contains various chemicals. Those are constantly dripping into the endometrial cavity, and if there is a hydrosalpinx fluid inside and you put the embryo transfer in, after the embryo transfer, it may not stick inside and that may lead to the failure. Also, the hydrosalpinx means there is a chronic inflammation in the body. There are lots of cytokines which are raised in the body. They will increase the immune factors in the body and that will lead to the rejection of the embryo, and that is why the hydrosalpinx need to be removed before the surgery. Now, couple of things. Some people say instead of removing, can we just do a simple fallopian ligation or a clipping of fallopian tube so that the backflow of hydrosalpinx fluid does not come inside, and then we can go for a transfer? Well, technically the answer may seem to be right. Yes, you are preventing the flow of the toxic fluid inside, and thereby you are keeping the endometrial cavity dry, and it can definitely work. But like I said, hydrosalpinx is not only about the collection of fluid inside the endometrial cavity, it also leads to the increase in the inflammatory markers, and that is why those inflammatory markers may go from the blood supply of the fallopian tube to the uterus and to the general circulation, and that may adversely affect the implantation of embryo. And that is why, while in an ideal world, I would advocate for the removal of ideally both fallopian tubes if patient decides to go for IVF. What some doctors do and some patients do, they say, let us try for first 1 or 2 cycles of IVF. If the IVF fails, then we will go for a removal of fallopian tube. While that approach is, from a cost-effective point of view, that approach can be taken. But like I said, in an ideal world, you should go for a removal of fallopian tube. I want my first IVF to be the best attempt, and that is why, if possible, ideally, patient should undergo the removal of fallopian tube before the hydrosalpinx before going in for a IVF. In which cases the removal of hydrosalpinx is not advisable. Suppose patient is a high risk for a laparoscopic surgery, we can just go in, put a fallopian and then clamp so that the toxic fluid does not come inside. Or in which there is a dense endometriosis, dense adhesions, the fallopian tube cannot be reached and fallopian tube cannot be removed. There is a frozen pelvis, everything is stuck up. Possibly in those cases you may not go for a removal. You can just simply put the clip and then do the IVF either next cycle or few cycles later. Many people come to me in which there is a gross hydrosalpinx and people have undergone either an embryo donation or an ovum donation or a self-cycle IVF and they have failed. And in those cases, I firmly believe that you have to remove hydrosalpinx before going in for a next cycle IVF. But if you have already done a laparoscopy, you found that fallopian tubes is, you have done a embryoplasty, you have opened the fallopian tubes and there is nothing, and the fallopian tubes have been compressed, then in those cases, rather than going in for a repeat laparoscopy before IVF for removal of hydrosalpinx, I would rather go for a cost-effective HSG before embryo transfer or IVF. If that HSG is suggestive that fallopian tubes are patent, but they are not hydrosalpinx anymore, then in those cases, the removal of hydrosalpinx can be postponed. So that way, the patient would be saving money on laparoscopy and we can have a decent advantage to the patient in terms of an IVF success as far as IVF success is concerned. Sometimes one point, I have done multiple thousands of HSGs. What I find is sometimes, because if there is a damage to the hydrosalpinx, some people come to me with a report of hydrosalpinx but the fibria is blocked. But because the fallopian tube has expanded so well, what I have found in my experience is people inject 10 ml dye only. Sometimes dye is not enough to come out. So I always prefer to do HSG with a 50 ml of dye plus normal saline. What I do is, once I inject, even if the fallopian tube fills, so the dye should be more than enough so that if there is a dye is completed at this place, if I inject more dye, then dye can come out at this place. So in conclusion, there are a few points I would like to mention. A, if you have been diagnosed hydrosalpinx on HSG, do not be disappointed. You can conceive. I have seen many patients who have conceived with hydrosalpinx naturally. If there is a hydrosalpinx and a patent fallopian tube, there are very good chances, 60 to 70% chances that you can definitely conceive naturally within the next 6 to 8 months. Even if there is a hydrosalpinx and one fallopian tube is blocked but one is patent, you can still conceive. Obviously the chances would decrease, but you can still conceive if you try normally. Not every case of hydrosalpinx requires laparoscopy. In hydrosalpinx, only those cases, if you have got bilateral fallopian tubes which are blocked, only those cases require laparoscopy. In good hands, if somebody is doing a laparoscopic embryoplasty, the fallopian tubes are open, you can still go in for a normal trial. Not every hydrosalpinx needs to be removed. Hydrosalpinx should only be removed if the patient is sure that she has tried enough of natural or IUI and she wants to go in for a IVF. So before embryo transfer, I personally believe every hydrosalpinx must be removed unless there are dense stuck-up adhesions, in which cases we put a fallopian. Hope you like this video. Sincere request to share the video and to subscribe to our channel. Namaskar. Bye-bye.